You're listening to the Beyond Nurse Residency podcast, an educational series where we interview experts on all topics related to the transition of new graduate nurses into practice and beyond. I'm your host, Nicole Weathers, Director of the Iowa Online Nurse Residency Program. Thanks for joining us. Let's jump in. So as nurses, our duty is to the patient. We spend countless hours putting the patient's needs above all else. And after long, exhausting shifts, we as nurses are often drained and unable to give that same care and consideration to ourselves. This, along with those continuous, small, but sometimes large traumatic events experienced day in and day out in healthcare, leave nurses feeling stressed, anxious, depressed, and burnt out, with the results really being workforce shortages and nurses leaving the bedside and sometimes the profession. So in this episode, we will discuss a new approach to nursing professional development and how we can begin to apply this concept to our work with new graduate nurses and nurse residency programs. So my goal for this episode is that our listeners will walk away with the ability to discuss these new concepts and have actionable steps they can take to improve their work. So I have with me today our guest, Heidi Gilroy. So maybe take a minute to tell our listeners a little bit about yourself.
So first of all, I'm so honored to be on the podcast. Thank you so much for giving me the opportunity to share about really my passion using professional development as a tool to enhance wellness in clinicians. So my name is Heidi Gilroy. I'm the Director of Professional Development Magnet and Research at Memorial Hermann, the Woodlands Medical Center. I've been a nurse a little over 20 years. Seems crazy to say that now. It seems like time has flown by. But I've spent most of those years being involved in some type of education, whether that be academic or clinical education. I love being an educator. I love being a nursing professional development specialist. I think it really is the greatest job in the whole hospital. It's also my primary research area. So I spend a lot of time not just teaching and learning, but also thinking about how we can teach and learn better as nurses. When I'm not at work, I love to travel. I love being outside, even though I'm in Texas and it's 100 degrees here right now, and love hanging out with our animals. We have 3 cats and 2 dogs, and that's kind of me in a nutshell. So thanks for having me.
Awesome. Well, I think there's nothing better than talking with somebody about their passion, right? There's so much good stuff, I think, to get from that. So I'm really excited to delve into this topic on trauma-informed professional development. Trauma-informed care is something many healthcare professionals are likely pretty familiar with. Trauma-informed professional development, though, it's at least a new concept for me. And I had the opportunity to hear you talk about it just a couple of years ago. So I think it would be great if we could start off by having you tell us about this concept of trauma-informed professional development and really where this idea came from.
During my PhD program and then during my postdoctoral training, I actually was in a public health setting. I moved outside of the hospital and was working in community and public health. And I was a part of a 7-year longitudinal study about women and children that had been involved in intimate partner violence. And as part of this study, obviously, I received a lot of training about trauma-informed care and trauma-informed approach. And so that was something that I was accustomed to using a trauma-informed approach in my communication and in some of my interventions that I was doing, even in the research study. So when the grant ended for the study, I decided to go back to the hospital setting, and I became a unit-based educator for a pediatric intensive care unit, which was actually the PICU that I had started my career in. So obviously I knew that the nurses there were exposed to really high levels of traumatic stress, both directly and indirectly. We were working with critically ill children and their extremely distraught family members every single day. So that's difficult for most people to take emotionally. So I did have that background knowledge, and I was a very young person too. I started my career, so I was kind of in my transition to practice dealing with that stuff. But I was surprised to find, as I was working as a unit-based educator back in the same unit, that many of my new nurses that I was training and helping to transition, they were exhibiting many of the symptoms that I had seen in the women and the older children that had been exposed to intimate partner violence. So pretty quickly, I got the idea we needed to do something to help the nurses with these traumatic experiences that they were dealing with that really were as severe as experiencing violence in the home. So once I had that idea, it was pretty easy to see the solution. I already had that trauma-informed approach training from my doctoral program and from the study. And I had the nursing professional development practice model. So I thought to myself, what happens if we combine the two? And that's really where trauma-informed professional development came from. It's really an integration of the assumptions and principles of the trauma-informed approach into the NPD practice model.
Do you have a definition of what trauma-informed professional development is?
Yes, and fortunately, we're coming out with a paper soon in the Journal of Nurses and Professional Development that really digs into this. So I was fortunate to work with a team of experts in nursing professional development as well as experts in trauma-informed approach. And we dug into the Substance Abuse and Mental Health Services Administration trauma-informed approach document, as well as in the scope and standards for nursing professional development. And we were able to kind of pick out things that were common to both. So you'll be pleased to know that a lot of the competencies and a lot of the things that we need in order to do trauma-informed professional development are already a part of our scope and standards of practice. So obviously, I'm not going to read you an entire paper. There's a lot of stuff in there, but essentially what we're looking for with a trauma-informed approach, and specifically with trauma-informed professional development, is the ability to create an environment where someone can heal after a traumatic experience. So we don't have to identify who has experienced trauma. We don't have to know if they're having any symptoms. What we're doing is we're making a big picture approach to creating a healing environment. So we already think about the learning and practice environment as part of our scope. So all we have to do is add into that, making sure that learning and practice environment is healing. That's it in a nutshell.
That's great. I love that. And I love the idea of we don't need to know who's experienced trauma to be able to provide an environment in which they can heal and, continue to grow. So, from working with new graduates for the last over 10 years now, people come to work with a lot that we don't know about, right? They have a lot going on in their personal lives. They've experienced a lot in the practice setting, and just being able to keep some of those things in mind while we work to support them, I think will really go a long ways. So I appreciate you sharing that with me, and I'm really excited to see that new publication come out. Is that expected soon?
It will be out in 2024.
Awesome. So speaking of publications, so recently you wrote an article. You talked a lot about safety in healthcare, but not how we typically think about healthcare safety as it pertains to patients, but instead you were really focused on this safety approach with the focus on the nurse. So maybe now you can talk to us about that. In the article, you mentioned 3 kinds of safety for nurses. So what are those? And then maybe we can go into, what healthcare organizations can do to begin to create that safe workplace, keeping all of those things in mind.
Yeah, this is a really important area, and I think an area that we're diving into a lot more, kind of post-pandemic. I think we can all agree that the COVID-19 pandemic was pretty terrible, but we did get several great things from it. Seems like we all have more awareness of some of the things that may have been festering below the surface, quality issues, DEI issues, healthcare disparities, and in a huge way, mental health issues. How often do we talk about mental health in meetings now versus 3 years ago? It almost never came up. And now it's a regular topic of conversation. And I think that's a great thing. And so safety is really at the forefront of all of this. So we want to make sure our patients are safe, our visitors are safe. And now more important than ever, both to direct care practitioners as well as hospital administrators, care team well-being and safety is also hugely important. So we'd already been talking a lot about psychological safety in healthcare. It's part of the whole high reliability organization framework to be able to speak up if you think there's a safety issue or even just a way to make a process better. And even beyond patient safety, psychological safety is important for organizational culture as well. So, I mean, any of you who are part of a magnet organization, you know that ANCC puts a huge emphasis on the empowerment of nurses to speak up and use their voice. There's a whole lot of literature to back that up. So we see outcomes like turnover, work culture, and mental health of nurses being associated with this ability to use your voice as a nurse. So in addition to psychological safety, nurses also need physical safety. So feeling physically safe is really important to well-being. So we think a lot about like specifically workplace violence or the actual physical events that happen to nurses, but we don't talk as much about just fear. So like, do our nurses feel safe walking through the garage, getting to work, after the sun sets, or even driving to work or getting on a bus or however they get to work? How do our nurses feel about our policies about weapons in the hospital? Like, are they fearful every day that someone's going to bring a gun into the hospital? And really, whether someone brings a gun or not, whether the nurse is safe or not coming to work, or whether something happens or not, that fear of injury, that fear of violence can be just as damaging to a person's well-being and really affect their feelings of physical safety. So that's so we've got our, psychological safety, we have our physical safety. The third type of safety is kind of a new concept. We really discovered that this third type of safety was an issue when we did an intervention mapping study with nurses to see how we could implement trauma-informed professional development at the system level. And the nurses that we talked to discussed wanting a sense of professional safety. And so I've been talking about this with more and more nurses as I've traveled around talking about trauma-informed professional development. And they really understand and resonate this concept, even though it's really not something in the literature, something that we have a lot of science behind. So professional safety is kind of being comfortable that you have the knowledge and resources you need to function as a licensed nurse without risking an error or risking your license. And a lot of nurses right now don't practice with professional safety. They might be working in a unit that's understaffed, or maybe they don't have enough training to deal with a certain type of patient or a group of patients that they're seeing in the hospital. They could even be floating to units where they don't have the competency or even know where stuff is. So these nurses are really vulnerable to making an error that could cost them their job or even their license. And so that can really affect your mental health. So if you're not secure that you know what you're doing and then something bad happens, it's much more difficult to deal with that outcome if you're feeling nervous and not confident to begin with.
So I would venture to say that this idea of professional safety is probably one that we hear a lot about from our new grads specifically, because, with the workforce shortages, with the staffing issues, we are pushing new grads to get competent quicker, right? We're pushing them through orientation. We're trying to get them out there working independently as quickly as we can because we need them. And a lot of times, they are feeling like they don't have the competence or the knowledge they need to be safe. And I think there is sort of a fine line a lot of times when you talk to leaders, when you talk to new grads about, are there going to be some new grads that never feel like they are knowledgeable or they don't have the confidence, or, not that they will never get there, but that it will take them a very long time. And so any thoughts on that? Like where or how you can determine, is it a sense of just their confidence, or is it that they do have more of that knowledge?
Yeah, so we're thinking about like social learning theory and, Bandura, and kind of the foundation of some of that. Some of the theory that we use in our practice is thinking about self-efficacy and building self-efficacy. And I think that is an extremely important piece of this professional safety. So just as an example, my new grads in the pediatric ICU, we had kind of incidences where the new grads were like, we're just not feeling comfortable, we're embarrassed, and we kind of were trying to dig in further, and they're like, you know what, we just want to be able to practice using some of the devices before we go into the room with the parents. So like one of the new grads described trying to set up pressure tubing. And I don't know if you've ever worked in an ICU, but if you set up pressure tubing, nobody looks smart setting up pressure tubing. You tangle up yourself and the pole and, you know, the small baby in the bed and everything else while you're trying to unwrap this pressure tubing and set it up. And so they were doing this for the first time while a parent of a sick child was staring at them, and how frightening that is and how nerve-wracking. So the simple intervention of letting them practice putting that pressure tube together in a simulated setting instead of at the bedside made a huge difference. And so these areas of self-efficacy, so one of the ways that we can increase self-efficacy is to help them have mastery. So any areas that you can help your new grad have mastery before they're exposed to that actual patient assignment or that actual area where they could potentially make an error and hurt somebody is really important. So, you know, doing skills days that help them get their hands on machinery, making sure that they have people with them the first time they do things and that they're kind of protected from these other things is really helpful with self-efficacy.
Reinforcing the idea that nurse residency programs or these transition to practice programs are going to be key in building that self-efficacy so that we do have that sense of professional safety.
Absolutely.
I mean, when you talk about this idea of professional safety, you know, I look back at my nursing career and I can identify countless situations that you're kind of forced into, whether it's floating to another department or we're going to have you cross train and then we need somebody to cover this shift and you're kind of off orientation. We're going to go ahead and have you do this. So many situations that you've been in where you feel unsafe as a nurse. You probably couldn't find a nurse that hasn't experienced that.
Absolutely. And we're really at a paradigm shift, I think, in the way of developing knowledge in nursing. So before we were knowledge storers as nurses. And I remember being a new graduate nurse in the pediatric ICU, and I had in one of my pockets of my little lab coat, I had my book, you know, my pediatric critical care little book. And in the other pocket, I had my little handy reference guide with medications in it. And all the knowledge that I needed were in those two books. And that's just not the truth anymore. Our nurses need such a huge span of information. They just can't remember it all, and they just can't keep it all in their brains. So we actually have to start training nurses how to be knowledge retrievers and setting them up to where they can retrieve that knowledge in a fast way so that they can make good clinical decisions rather than being knowledge storers. So rather than pumping them full of you know, kind of didactic knowledge in their head, we really have to get them to be able to find that knowledge exactly when they need it.
I 100% agree. I mean, I think we are at that point where there is no possible way for a nurse to know all the things that they need to know to do their job because it's constantly changing. I mean, there's new equipment, there's new technology, there's all of the things that are changing every day in healthcare. I always say the only constant thing in healthcare is change. And so I think you're spot on. So you got into self-efficacy a little bit. And I think in your article, you talked too about threats to professional safety or threats to the nurse's mental health. And in the last 3 years, we talked about that rise in trauma, anxiety, burnout in the profession that's leading to turnover and nurses leaving. So, you know, clinician well-being has been identified as a systems issue. There are many issues needing to be fixed within the healthcare system. There's also individual factors. And so that's where I'm always like on this. I feel kind of caught in the middle sometimes because I do agree there's a lot of things in the healthcare system that need to be fixed in order to improve the mental well-being of our bedside clinicians. But there is sort of that individual factor that I think is also essential. And I think this is particularly true in new grads and kind of goes back to this idea of self-efficacy that we got into just a minute ago. So this concept that I've been reading a lot about, psychological capital, and what psychological capital is, and maybe now we can delve into how NPD practitioners can begin to help build towards this. So we talked about self-efficacy, but maybe you can go back tell us a little bit more about what psychological capital is and if there's other things that we can do beyond helping with mastery to begin to build that in our nursing staff.
Yeah, I think that really the two major areas that especially NPDs can assist with psychological capital are really that self-efficacy and peer support. So let's start with the social peer support, because I think it's the easiest concept to understand in an area we already know works with new grads. A big part of nurse residency program models is bringing the new grads together with mentors, bringing them together with each other, with leaders, with residency coordinators. We love to get new grads all in a room together to talk. It's like a huge part of what we do. So they need that social support as they're going through the process of transitioning to practice, and we know that. But we're probably just scratching the surface of what social support actually means, not just for the new grads, but also for more experienced nurses. So we did a Delphi methodology study with our newly licensed nurses to determine which relationships were more important to them in their transition to practice, because obviously we know that support's important. And some of the answers were obvious, they mentioned their leaders, the clinical coaches. So we often address that in our residency program. So we're already training leaders, we're already training the clinical coaches in how to interact with folks going through the transition. But some of the really important relationships that the new grads said were affecting their transition to practice were not directly related to their orientation. So people like their family members, they talked a lot about friends who were also nurses and had the same experience. So it might be a friend that they went to nursing school with, or maybe even an older person that they knew who had been a nurse before. And then connections, and this is really important, connections that they made with other staff on the unit. So those forming friendships that they started with people that were working with them on the unit. So these were some of the very most important relationships to them for their transition to practice. So as an NPD, I obviously can't control what relationship our new grads make, but we can teach them and we can connect them with other people. So we can teach newly licensed nurses how to leverage the supportive relationships that they have both outside and inside of the hospital, not just now, but also for their future transition. So if they're changing jobs, becoming a charge nurse. So kind of thinking about those relationships and how they affect future transitions. And then even just kind of dealing with the unusual lifestyle of being a nurse. How can we leverage that friend who's also a nurse? Will they drive with us to Walmart at 2:00 in the morning to make cookies because they're up at the same time? So kind of understanding those relationships and how important they are. And then we can also really connect new grads with their colleagues on the unit through strategic conversations. So even, getting one of our more experienced nurses to sit down and have coffee with one of the new people, or maybe that your new grad has something in common with one of the nurses that are on the unit and can just come in and kind of tell the new grad and the other nurse, hey, you both guys really love baseball, and maybe start a conversation. So some of these facilitating techniques of getting people to talk to each other and really start building those relationships. And another part of the social support structure in the unit really is the NPD practitioner themselves. I think most of us who've ever been a unit-based educator especially knows that, our office is kind of the chatting zone. People come by to talk about what they're annoyed about, what they're sad about, what happened at home, what happened in the unit. And so we really make a difference in peer support for the new grads. So I mentioned earlier an intervention mapping study that we did for trauma-informed professional development. So another finding from that study was that the nurses felt very supported during their onboarding and orientation, but kind of felt abandoned afterwards. So they still needed that support. They needed the leader in the NPD to come by and check on them, but suddenly they didn't have the scheduled 1 or 2 week connections with those folks. They would have to actually seek them out. And so they kind of felt abandoned. So creating purposeful connection points between the NPD and the new grad or experienced nurses is really important. You were talking about individual issues, and I think this is a really important thing for folks in transition to practice programs to understand. So there are a lot of individual characteristics of new grads that put them at greater risk for mental health issues. Some of them already come in with mental health issues. Some of them have experienced really horrific things in their life. I'm working with our local university to do a study of new graduate nurses, and we have found that twice as many of the new grads at this school have experienced 4 or more adverse childhood events, essentially things like child abuse, neglect, something that happened during their childhood that could traumatize them. They've experienced those things at a much higher rate than the general population. So by the time they get to us, they already are kind of at this risk. So these folks are going to have much more difficulty interacting with some of the traumatic experiences that they'll find in the workplace. So they're, a patient dies and one of your new grads experienced child abuse as a child and one of them didn't. That one that experienced child abuse is going to have a much harder time dealing with that. And no one ever tells the new grads this. No one ever says, hey, you've experienced this in your life, and as a result, you're going to have more trouble with some of these issues that come up in the hospital setting. And so it happens and they feel surprised, they feel frightened, they feel crazy, they feel like something's wrong with them. And so if we could just let graduating nursing students and nurses transitioning to practice know that these are things that might happen to them. And it doesn't have to be just adverse childhood experiences. It could also be, sexual assault during college. It could be they might be in an abusive relationship at home. And again, we don't have to identify these traumas or know about them. In fact, it's none of our business. But we do have to prepare the group as a whole. Like I was talking about before, trauma-informed professional development is really creating an environment that's healing. And so when we have this environment that's healing, we also have conversations that say, hey, if you've experienced these things in the past, don't be surprised if you have a more difficult reaction. And so even that awareness and that understanding can help someone get through those situations.
Oh my gosh, like as you're talking about this, I'm thinking back, you always like flash back to your nursing career in certain situations where like my first death was really hard. And, thinking about what were maybe some of the childhood things that could have impacted that or, made that be such a difficult time for me. And I was 5 years old and watching my grandfather like drop dead in front of my eyes. And that was hard for a 5-year-old to deal with. And then my very first death as a new nurse, like, was also very hard because I lived in a small town. It was actually a friend of mine's grandfather it was my first patient that I ever had die. And so, as you're sort of talking about this, it's like, oh, that would have been helpful to know that was probably going to be a thing and that there wasn't something wrong with me, that I had a hard time, dealing with this, but that, it would potentially be expected that would be something that would bring up a lot of thoughts and feelings and unprobably dealt with emotions from many, many years ago.
Yeah, when you're a child and your brain is forming and those things happen, it changes the actual structure of the brain. And so sometimes we feel kind of weird or out of control if we have these reactions, but it's really based on how our brain developed when we were kids. And, what you said is a statement that I've heard from lots and lots of nurses. You ask nurses, why did you decide to become a nurse? And they have a story. And usually it's a traumatic event. They were diagnosed with some kind of a condition as a child. I was diagnosed with type 1 diabetes in 1984. So I was a 3-year-old, in the pediatric ICU. And one of my very first memories it's funny, it's of a nurse. You would never do this now, speaking of safety, but she clicked off the needle part of the syringe and gave me a little styrofoam cup and taught me how to spray the doctors passing by with water from my little syringe. So in my case, I don't feel that as traumatic, but it was a situation for a child that was very, very weird and odd. And yet I find myself drawn to that same place where I experienced that to take care of other people. So I think if trauma is such a big part of why nurses choose to become nurses, And this is really true for a lot of the helping professions. We know from research that a lot of other helping professions, social workers, other folks in the hospital along with us are experiencing the same kind of thing. They choose to be in this role, in this profession, because something happened to them. And so, really at the beginning, it's more challenging. But we also have the opportunity, sometimes this is kind of a bummer subject, talking about trauma and what we have to deal with every day. But we do know that there's also trauma, post-traumatic growth. So growth and improvement and great things that happen as a result of being exposed to trauma. So we have the opportunity not just to have symptoms and not just to have some bad outcomes, but we also have the opportunity to have some great outcomes. And I think NPDs can kind of participate in that too. So making a learning environment where not only are people protected from having bad outcomes, but having a learning environment where really they can even elevate above their prior functioning and do even better, be even more connected with patients and their colleagues, be even more open to possibilities, be even more, connected with their spirituality or their religion as a result of those experiences. I think that puts us in even a more, important position in the lives of these new grads where we can kind of help them to elevate to that growth level.
I love that. Yes. I mean, I think that is such good. And I think I could listen to you talk about this topic all day. It's so interesting to me. So I want to circle back to what we were talking about just a couple minutes ago regarding residencies and how you said, we love to get them into a room and offer this peer support. And then they feel like eventually they lost that, right? The need to help them grow the social support. So, that is something that we've talked a lot about with the people who use our residency program is, yes, it's about that personal mastery and all the topics that we talk about related to like, the professional skills of being a nurse. But this support piece, I think, cannot go unemphasized because we always say we can do so much as residency coordinators to help grow their skill set, but they have got to have somebody on the unit that's connected with them, that cares about them, that cares about how they are doing things. And so we've really encouraged check-in points throughout the residency program from these people on site. So I just wanted to kind of go back and say thank you for bringing that up, because now it's not just me saying, I noticed that this makes a difference in their engagement in the program and their completion rates, but that there's actually science to support how important that social support and those social connections back on the unit are.
Absolutely. And this is actually an area when we were doing our work to see what parts of trauma-informed approach are actually already in the NPD scope and standards, and peer support is not as highlighted in there. So I think it's something we do as part of everything else we do, but maybe we haven't talked about it a lot or trained on it, or it's not a competency we're checked off on. So, a focus on that and helping NPDs get better at that is really important. And I just want to say, as far as the peer support, thinking about a trauma-informed approach lens, so peer support in the trauma-informed approach is someone who's also experienced the same type of trauma. So essentially the person is helping you heal, not just by their presence, but also by their experience. And so having an NPD, like me and you, we both experienced a death, in our past, in our work, early on in our nursing career, and we dealt with it. And so using that trauma in our own lives to then reflect with the new grad is hugely important. I talked a little bit about really nursing self-efficacy. So the new grad feels confident in their nursing skills, but there's also such a thing as coping self-efficacy. So essentially, the definition of self-efficacy is really the belief in one's own ability to survive something or one's own ability to accomplish something or have success in something. So coping self-efficacy is just a person's belief that they can cope with something. So you get a diagnosis of cancer. immediate first thought, can I cope with this? Do I have the coping mechanisms to survive this? Same thing happens at work. Like, if one of these new grads does an error that hurts someone, or if one of these new grads, experiences a difficult patient death, the first thought that they have is, how am I going to get through this? How am I going to cope with this? And so if we're able, as a peer support who's also experienced these same things, if we can help with that coping self-efficacy, build up not only their coping skills, but also their confidence in their own coping skills, we can really make a huge difference in their ability to confront some of these first traumas that they have when they're getting into their practice.
Yeah, absolutely. And I think also having residency programs, having those one-on-one discussions with them are the only ways sometimes to learn that they are struggling with some of those things, that they have had some of those first traumas, as you said. Otherwise, they just hold that inside and they ruminate on it and they can't let it go. And so I think as NPD practitioners, as people who are running residency programs, whether we're the one reaching out or we're coordinating some of those connections with other people on the units, that is how, from what I hear you saying, that's really how we begin to cope with the traumas that we are experiencing. And that's how we begin to kind of move past that and grow that self-efficacy at the same time.
Absolutely. And I think it's important. Some of the folks, so when you're talking about making connections, some of the folks that are actually having symptoms, like you were talking about, sometimes it's hard to identify unless you're talking to them face to face. Even when you are talking to them face to face, sometimes it's hard to identify as well, because these folks that are having symptoms of trauma exposure, they're going to have avoidance symptoms. They're not going to want to talk about it or think about it or even be where the trauma happened. So that's going on. They might have some mood changes. So they might be kind of jumpy or actually have angry outbursts and things like that. They might have intrusive thoughts and have difficulty concentrating. So this kind of paints a picture of someone who's having difficulty with a residency program that's maybe not going to cut it. Maybe your preceptors are saying, yeah, this person they can't remember which patient's room to go in first. They can't remember how to do this. They get distracted. They're grouchy and all this stuff. And it sounds like an education difficulty when it really is a trauma difficulty. And I think sometimes folks that have experienced that same type of trauma and have experienced those same type of symptoms can have more compassion. So preparing your preceptors as well, thinking about those social support connections to understand that some of those symptoms can be trauma related and not, kind of education related, and giving them some simple strategies to intervene, then that can be a really powerful intervention as well and can help you as the NPD. If you're not able to be face to face every single day with every single new grad you have, at least you have preceptors who have some of that same knowledge and can provide that peer support as well.
Yeah, and that is huge, because how many times have we heard like, this new grad's just not going to cut it, right? They're struggling with this, or like you said, they're not remembering that or whatever. And we take it so much at face value sometimes when there's probably something much bigger going on.
Absolutely. I saw a little meme the other day, and I'll just read it to you because I think it's really important here as well. It says, when the stories about a student are saturated with negativity, have the courage to not join in. Tell a story of their unique abilities and moments of kindness. Tell the story of hope. And this is really thinking about a classroom and, a young child, but I think the same can be true about a nurse. And, you'll start to hear about a new grad, oh, they're just not going to make it. And, some of the preceptors will start talking to each other and then other folks in the unit. And if we think about kind of the trauma-informed approach and trauma-informed professional development, that can really blockade a lot of the potential interventions we have with self-efficacy, with social support. I mean, if the people around you don't have confidence in you, it's hard to have confidence in yourself and build up that self-efficacy. And if people are talking about you, it's hard to reach out to them for peer support. So I think as NPDs, we can also change the conversation and use that hopeful language and identify some of those areas where they're succeeding to help not just the new grad, but the folks around them to really be hopeful about that person too.
Yes, that's great. So, these topics that we've talked about today obviously are important for any nurse in any stage of their career. Why do you think it's particularly, though, important for new grads?
Trauma-informed professional development specifically. So there are some risk factors that new grads have kind of by definition. So younger age is a risk factor for developing some of the conditions like post-traumatic stress disorder. These folks are really, so we talked about potentially having someone coming from a traumatic background or experiencing some past trauma, and they are for the first time experiencing these re-traumatizing factors that are really, able to kind of start that symptomology up all over again. So maybe even if they recovered in childhood, they are re-traumatized. And so this is the point where they have these experiences for the first time. So that's kind of a big deal. And certainly the stress around transition to practice. I mean, we've been talking about stress and crises of transition to practice and all of these things really since the 1960s as a profession. So this isn't anything new. We've always known that new nurses go through really stressful periods of time. Because, I mean, let's think about it. Not only are they coming to learn a whole new job and a whole new profession, a lot of them are out of the house for the first time, maybe getting an apartment. They're trying to figure out how to buy a car. They didn't know insurance was that expensive or cable. They don't know how to budget. They might be getting in a relationship for the first time, a romantic relationship. So all these things are going on. And at the same time as they're having this really stressful transition to practice. So having stressful life events around traumatic experiences can put you at more risk. So definitely these guys that are in this first year or so, there's a lot of stuff going on that makes them more at risk for some of the poorer outcomes. And also, we don't want to lose them at this point. They've worked really hard to get here. They've gone through school. They've gotten, many of them did many interviews to try to get where they really wanted to go. And so, we really owe it to them to help get them at least through this first couple of years so that they can be successful in their future role.
So, if our listeners wanted to look at their residency program from sort of a trauma-informed lens, I guess first, like where would you suggest is a good place to start, and then where might they find like some quick wins?
Yeah, so the Substance Abuse and Mental Health Services Administration has a document about the concept of trauma and the principles of the trauma-informed approach. So this is really the foundation. They're the ones that made this all up. So you can go straight to the source and look at that document. And I think you listeners, just like me, will find as you're going through this, gosh, a lot of this stuff is really what we're doing already. And so just starting to integrate those things into your practice. The 4 assumptions of the trauma-informed approach that you'll find there at that SAMHSA website or the SAMHSA document are that we want to realize the widespread impact of trauma. We want to recognize the signs and symptoms of trauma. We want to respond with evidence-based interventions, and then we want to resist re-traumatization. So these are kind of the 4 steps to go through in order to address trauma, in order to make this healing learning environment. So one of the things that you can do just at the very beginning is to start with the first R, to realize. I think awareness makes a huge difference in the way we interact.
I love it. Oh my gosh, we have talked about so many good things today. We've talked about trauma-informed professional development. We talked about safety. We talked about self-efficacy. Before we go, I have one last question for you. So when it comes to transition to practice and our topic today, what's one thing you often see organizations doing wrong or maybe wasting resources on that really isn't making a difference for their new grads? And what would you maybe tell them to do instead?
Yeah, I think this goes back to what we were talking about before with nurses being information retrievers as opposed to information storers. We are still, just like in decades and centuries past, trying to teach new grads every single thing that they need to know in these didactic classes and really overfilling their brains, which I think causes them problems in more than one way. First of all, it sets up the expectation that they're going to be able to remember all this stuff, and that it's just an unrealistic expectation. And that kind of sets them up for failure because they'll have that stress around that, which, as we mentioned, is increased risk for some of these poor outcomes of trauma exposure. Doing this kind of old-fashioned method of teaching new grads, I think, is really doing a disservice. And our academic partners are actually really far ahead of us. They have started transitioning to a model where they're really getting the people, the students in front of them, the exact information that they need right when they need it, and really focusing on skills and applications of things. And I think we can do the same in the hospital setting. Just thinking of a new graduate nurse who's already worked in the hospital 10 years, maybe in the business office or maybe even as a patient care tech. Do they need hours of education on communicating with patients and families? Probably not, because they've already been doing that. Or if, they've worked in a specific area, do they still need to go to the class on clocking in and using the scheduling functions? So we're still making everyone go through every single piece of the classroom model. And I think we need to move past that and really start to personalize our new graduate education for the people right in front of us. And there's a lot of ways to do that. I think, doing a better job at that environmental scanning, knowing what they need to know and knowing what they already know, and really having good conversations. A lot of people ask me when we're talking about trauma-informed professional development, how do I know something? How do I know if the information is traumatizing? How do I know if this experience is causing more harm than it's worth? How do I know if my, learners really need this stuff? And my answer is very simple. Ask them. I think sometimes we want to think of some really complicated way of designing education for people. And one of the best ways we can design education is by having the learners design it with us. And that is really a part of trauma-informed professional development as well. One of the principles of the trauma-informed approach is empowerment. So having the learner control their own destiny, kind of choose your own adventure with learning can actually be a trauma-informed intervention as well. So I hope, in this, the next few decades, we'll start to see that shift and that the hospitals will move to what our academic partners are already doing and really personalizing education to each person that comes through the door.
That is a awesome idea, and I think something that gives us a lot of food for thought as we close out our conversation today. So Heidi, I just want to say thank you so much for your time and your expertise in sharing this passion of trauma-informed professional development and professional safety with all of us. So I know it's given me a lot of good things to think about, and I know that that is also true for our listeners. So I appreciate you and all of your work. And, we might have to have another conversation again like this down the road.
I would love that. Thank you so much for inviting me. And just for any listeners out there, I would love to connect with you and help you with your thoughts about trauma-informed professional development, because this is a developing concept. This really is going to require all of us to get this to our new grad nurses and our experienced nurses and make a big difference. So reach out. Would love to partner with you on any research or projects that you're working on.
Well, thank you, Heidi. Thank you, listeners. And we will see you next time. Wait, before you go, I want to make sure you know about all the resources you can use to support your new graduate nurses. This includes our Academy, a coaching program designed for organizations as they prepare to implement and sustain a residency program. Work one-on-one with a residency program expert to make sure your organization is residency ready. Then we have our online nurse residency program. This is an evidence-based, comprehensive curriculum designed to support your new graduate nurses as they transition from school into practice, wherever that might be. We focus on professional skills, personal well-being competencies, and new graduates even get the opportunity to create real change in their own organization. How cool is that? And we can't forget about our Supporting Nurses course, an asynchronous continuing education course for preceptors, mentors, and coaches to learn the skills they need to support any new hire. You can learn more about all of these resources and everything we have to offer using the link in the show notes below.